Hello, everyone, and welcome to the 6th World Sepsis Congress. My name is Zahra Hoodbhoy, and I'm an associate professor in the Department of Pediatrics and Child Health at the Aga Khan University in Pakistan. I have the privilege. Hello, everyone, and welcome to the 6th Sorry about that technical glitch. I hope this is better for everyone. I have the privilege of moderating today's session on survivorship, long-term outcomes, and rehabilitation in children and women. We have today an excellent lineup of speakers, including survivors, patient advocates, and leading experts in the field. We will be having about 5 talks in this session. After a brief introduction of each of the speakers will speak to you for about 12 minutes, after which we will open the floor for Q&A. Please feel free to share your comments and questions in the YouTube chat, and I will do my best to bring them into the conversation. So let's get started. Our first speaker for today is Ms. Brea Kunstler. Brea's journey is inspiring. After 3 pregnancy losses in less than a year, Brea and her husband turned to IVF in 2023, hoping for a new beginning. But what was meant to be a routine egg retrieval quickly became life-threatening. Within 48 hours, a group A streptococcal infection progressed to severe sepsis, requiring emergency surgery and life support. She survived, but the recovery was long, marked by post-sepsis complications and months of rehabilitation. And yet, just 2 months later, she conceived naturally, and in March 2024, delivered a healthy baby boy. Today, her story is not just about survival. It's a powerful reminder of why early recognition of sepsis can mean the difference between life and death. Brea will be talking to us about beyond survival, long-term outcomes after maternal and neonatal sepsis. This will be a pre-recording session, and there will be no Q&A for this segment.
Welcome, and very much welcome to you, Brie, for being part of this session. Brie, you're here as a sepsis survivor, and really what we'd like to do is find out a little bit about your experiences, but also importantly, learnings that you feel able to share with the wider sepsis community. So first, can I ask you to tell us a little bit about yourself, your background, where you're living in the world before sepsis struck?
Yeah, so I'm from Melbourne in Australia. I have, at the time sepsis struck, I had a young daughter who was 3. Professionally, I'm a physiotherapist and a behaviour change scientist, and so I was working full-time at the time. But I think importantly, I was going through IVF, and it was the experience of IVF that actually led to my time with sepsis and in the hospital with sepsis.
Okay, that's fantastic. And then perhaps if you can start to tell us when you got sepsis, about actually when was that relative to today, a little bit about that, and then we really will come on to more about how was your recovery, but I think we need to understand the background to where you were recovering from first. So please go ahead and share what you're comfortable with, Brie.
Yeah, so that was almost 3 years ago to the day. My husband and I were going through IVF, and it was our second round. The first round completely failed. And IVF can be quite intense. So there's a lot of injections, a lot of personal psychological and physical commitment to an expensive process. And as part of that process, I needed to undertake a relatively simple surgery called an egg collection. So that was where basically I took several hormones, a couple of hormones over several days to create a lot of eggs, and then they had to be harvested in this procedure. And during that procedure, group A strep was introduced to my abdominal cavity, where it shouldn't be. And that made me very, very sick. So after an egg collection, it's pretty standard to recover quite easily. You do have a general anaesthetic, so I would say the majority of the recovery is actually just from the anaesthetic. First time I had an egg collection, I was up on my feet pretty much straight away and looking after my daughter in the afternoon without any issues. But the second egg collection in the afternoon, I was actually quite sick and continued to deteriorate over the next 12 hours with very gastro-type symptoms. And when I read about how sepsis survivors, that they say that they felt like they were going to die, I felt like I was going to die. So yeah, it happened very quickly. The deterioration was quite quick. So I had to get help quite quickly.
Okay, thank you. And I guess in terms of what happened next, briefly, maybe you can sum up what happened to you, but also perhaps, yeah, what do you think could have been more impactful at the time? Maybe we'll come back to that, actually. Yeah, just what happened next, and take me through the next few steps.
Yep. So as I started to deteriorate, I called my fertility specialist and said, "Hey, what's going on? I feel quite sick." And he assumed that I had ovarian hyperstimulation syndrome, which is a common condition to have after stimulating the ovaries with the hormonal treatments. But with the prescription of endone and ondansetron having absolutely no effect, he said, "Look, these drugs should be working. You need to go to the ED or the emergency department." And so my husband called for an ambulance, but I was deemed a lower priority. And so I took a ride share to hospital and managed to get there within 10 minutes, which was remarkable. I'm not sure how the ride share driver felt about the whole situation. But once I got there, the ED staff were absolutely phenomenal. I told them quickly about what I had been through with the surgery, how the medication had no effect, and they quickly whisked me away straight to be triaged and straight into resus. And once they measured my vitals, they realised that maybe ovarian hyperstimulation syndrome wasn't my main issue at the time, since my heart rate was, I think it was 150, and my blood pressure was 90/50. So they quickly assessed me and considered the potential for sepsis.
Okay, that must have been quite frightening for you at the time. And maybe if we can just kind of move on through what happened, and briefly what happened to you in hospital in the next days, but then I think really importantly, yeah, how were you, when did you start to realize that you were going to make this and be recovering?
Yeah, so resus was quite eye-opening. I have a background in physiotherapy, and so when I saw my vitals, I knew that was odd. A normal, healthy human being should not have a heart rate and a blood pressure of that. So that was quite confronting. So sometimes knowing more isn't actually a good thing. And the fact that the doctors couldn't get an IV in and that I had to have a CVC to administer the drugs. And at one point, I think I had something like 7 doctors in the room and 4 nurses. And I thought, it just seems like a lot of doctors. And that's when you think, this is kind of serious. And I was quite lucky when it comes to pain at the time, because I was in quite a lot of pain at home. But when I got to hospital, they addressed the pain straight away. And I thought, actually, maybe I could go home. The doctor said, look, no, you won't be going home. You'll be going straight to ICU. And so I spent a couple of days in ICU before I had an abdominal washout to clear the infection. At the time, the doctors didn't know what the infection was. And so they were kind of going in blindly with the abdominal washout. And obviously they took samples while they were there and were then able to determine what was causing my symptoms and prescribe the appropriate medication. So I'd say all up in hospital, I was there for about 7 days. In ICU, probably 4 of those. And I still think today I was very lucky to have medical staff that had that differential diagnosis. So we're thinking outside the box. It was very easy to just diagnose me with ovarian hyperstimulation syndrome, but they thought outside the box, they thought quickly, they acted quickly. And, that's probably why I'm here today. And after having the surgery, I really only have 3 little scars on my tummy, and that's about it when it comes to physical scarring or any sort of physical defects on my body. Using my physio knowledge on the ward, I basically rehabilitated myself and did laps of the ward and went up and down the stairs and convinced them that I was ready to go home at that 1-week mark. But it was just remarkable, that first walk around the ward, and I was just exhausted. I couldn't believe it. Before I went to hospital, I ran half marathons. And just that time with sepsis, that time in ICU and having surgery, took me back to a point where one walk around the ward and I had to have a rest. And that was shocking.
Yeah, I can imagine that impact, particularly on you, even with that knowledge. And let's talk a little bit about the physical side of things. So how did things evolve, and how did you begin to recover physically from there? So you were walking around the ward, you were doing stairs. Were you carrying out discrete exercises? Did you continue that after you went home? How did it work?
Yeah, so upon discharge, I went home to my family. It's funny, as a mum, you just walk straight back into that mum role. And it just, it made me think, oh, hang on, I can't really just put my feet up. I need to actively rehabilitate myself here because I have a job to do. And I went for a walk to the pharmacy on the first day I was home. And previously that would have been super easy, but there was a couple of times I had to take a break. And so I realised that my physical recovery was going to take some time. And I never really got back to that half marathon running distance for various reasons. I actually conceived my son 2 months after sepsis, so pregnancy kind of got in the way there. But I would also say that it was very difficult to get back to running just because of the exhaustion. It's just physically hard to get up in the morning, to get out and run. So I slowly progressed maybe up to about 5Ks and couldn't really get past that. But I was still able to do normal activities of daily living. So I was still able to care for myself and others. It was really just the physical performance side of things that was greatly impacted. But I would also say psychologically, there were some challenges there. I don't think you can go through sepsis and come out psychologically perfectly well, because it's a life-threatening situation. That's what everyone needs to realise. It really is life-threatening. And for anyone to be put in a life-threatening situation, that can be quite challenging. So it was coming to terms with the fact that, yes, I actually almost died. And and experiencing sepsis from a surgery that was so routine and so low risk was just considered bizarre by the doctors treating me, by the specialists. So to be that, 1 in 10,000 makes you think, why me? But it also kind of puts you off having any other kind of invasive procedure. Even just having, I had a benign skin cancer removed, and I was really stressing about that, thinking, oh, what if that leads to sepsis again? So, yeah, it took a bit of time to recover from that. And I would say even 3 years on, I'm still conscious that any sort of invasive procedure has risks.
Yeah, thank you. Well, and thank you for sharing that as well in detail. I guess one of the things we'd like to do here as well is think broadly, what are the main messages to people who might be listening to this session around long-term outcomes from sepsis? What it sounds like actually the recognition was very quick, but and treatment very appropriate when you made it to hospital. So, but what can we learn in terms of how we think about the longer term aspects of people coming out of sepsis?
Well, time is life. Time is life, absolutely. And not only should clinicians be thinking, could it be sepsis, but also people in the community should be thinking, could it be sepsis? Because in my situation and the situation of thousands and thousands of other people who have experienced sepsis, the first responders for them are not healthcare professionals. It's their family, it's friends that are around them, work colleagues. And so I think it's key when it comes to identifying sepsis and recovering from sepsis to empower the community. And when I say community, I just say everyone. We're not just talking about healthcare professionals here who have guidelines, who should be thinking outside the box. Community members are the ones who see the people who are in the early stages of sepsis at their most critical, and they're the ones that will have the opportunity to act fast. So I think going forward, when it comes to improving sepsis care more broadly and therefore sepsis outcomes, we need to focus on empowering the community through not just knowledge but capability. So we can improve knowledge and awareness of sepsis, and there are wonderful organisations and wonderful conferences that are acting to improve the awareness of sepsis. But I think empowering people to act is really important. So if I can give an example of the FAST stroke guidelines, people are aware of the acronym and what FAST stands for, and that empowers them to act quickly because they know what they're looking for. We do have signs of sepsis that we can look for, but what we need to keep in mind is that for a typical community member, those signs look like the signs of many other serious illnesses as well. So we can empower people by giving them resources and easy to remember acronyms on the signs of sepsis. But I think what we need to focus on is ultimately the outcome that we need from them. We need them to get help fast. So if they see any of the serious signs of sepsis or any other serious condition that it could overlap with, just get help. That is the main message.
Right. Thank you, Bria, and that's a wonderful point to end on. So thank you very much for sharing your experiences and also all the work I know that you are doing to help support sepsis and sepsis survivors. Thank you.
Right. Thanks, Louise.
Thanks, Brie. For sure, that was very inspiring. And as someone mentioned in the chat, time is life. So early identification of sepsis by non-specialists is critical. Let's move on to our next speaker. Our next speaker is Ms. Kristine Russell. Kristine is a Canadian sepsis survivor and patient partner whose work is deeply rooted in lived experiences. In 2014, following the birth of her daughter, both she and her newborn developed life-threatening Group A streptococcal sepsis, a turning point that shaped her commitment to improving how care is delivered and experienced. With over a decade of experience in healthcare communications and system-led improvement, she now works with organizations like Alberta Health Services, Sepsis Canada, Canadian Institute of Health Research, and WHO, supporting advancements in maternal and neonatal sepsis, patient engagement, and health system improvement. Kristine brings a powerful perspective, bridging patient experience with system-level change, and is a strong advocate for integrating patient voices into research, policy, and care. Kristine's topic, as you can see on the screen, is not fully recovered, post-sepsis care for children and families. Welcome, Kristine.
Thank you. Hello, everyone. My name is Kristine Russell, and I use the pronouns she and her. I'm joining you from my home in Mesnat, Alberta, Canada, on the traditional lands of the Blackfoot people. And today I want to share a story about survival, but more importantly, about what happens after survival. Because Ellie and I survived sepsis, but we were not fully recovered. Before I continue, I just want to share that there are a few images from the NICU in this presentation that some may find difficult. In July 2014, I gave birth to my third child, Ellie. She was born full term, clinically healthy, with a routine, uneventful delivery. And like many moms who had done this before, I was ready to get home and settle into a routine with my two young boys, who were 3 and 5 at the time. Everything felt normal. But just 4 hours later, everything changed. Ellie suddenly stopped breathing in my arms. She was rushed to the NICU, and within hours, she began to show signs of sepsis. Overnight, I began to deteriorate as well. The next day, we learned it was caused by a severe Group A streptococcal infection. Within 24 hours, both of us were critically ill. Because we lived in Medicine Hat, which is a small community just 3 hours southeast of Calgary, we had to be airlifted separately for life-saving care and placed in isolation. During that time, my husband had to drive 3 hours alone, not knowing if either his wife or daughter would survive. He also had to arrange care for our 2 young boys at home. Ellie spent 19 days in the NICU, and we were told to prepare for the worst. At that time, understandably, the focus was on survival. This picture was the first time I was able to hold her again, which was 4 days later after being admitted on my 34th birthday. Everything about this moment actually was relief, but also fear and uncertainty still. Even then, we didn't know what the outcome would be. Over time, Ellie stabilized. We were transferred back to complete treatment, and eventually we were able to go home. From the outside, it looked like we had made it through. We were discharged, clinically recovered, but not fully recovered. We survived sepsis, but no one told us how to recover. When we left the hospital, I remember asking what recovery would look like. The answer was uncertain. We were told we wouldn't really know the long-term effects until Ellie began to develop. There was no clear roadmap, no structured follow-up plan beyond a single post-NICU appointment 1 month later. As a parent, that uncertainty feels overwhelming. It feels like you're just left to figure it out on your own. And what stood out to me was the contrast. For preterm babies, there are well-established follow-up pathways. But for a full-term baby who had survived severe sepsis, there was nothing beyond routine care. There was no clinical framework guiding what came next. And over time, those gaps became very real. At about 2 years old, Ellie had her first seizure. She began experiencing ongoing health challenges, and we spent years navigating appointments and uncertainty. At the same time, I developed post-traumatic stress disorder, though I didn't recognize it right away. And none of this was identified or addressed within our care pathway. The trauma didn't just affect Ellie or me. In pediatric sepsis, the patient may be the child, but the experience belongs to the entire family. When I reflect on our experience, it wasn't that care wasn't there. We were transported for life-saving care, treated by incredible teams, and brought back to complete treatment. But that level of coordination didn't extend into recovery. And that gap isn't about one person or one team. It's about how the system is designed. Looking back, there were moments where simple conversation, a check-in, or even naming what we might experience could have changed how we navigated the years that followed. If you're a clinician, you might be thinking, what does this look like in practice? From our experience, even small changes would have made a significant difference. Telling our family what to expect after discharge, not just medically, but developmentally and emotionally, even just naming that uncertainty would have helped us prepare. Naming the possibility of trauma early, because when it's named, families can recognize it and actually seek support. Ensuring follow-up is intentional, not incidental, and recognizing that when a child experiences sepsis, the entire family is impacted. These aren't large system changes. They are small shifts that can change how families experience recovery. Today, Ellie is 11 years old. She is strong, resilient, and doing incredibly well. And our family has found a way forward, but we're not untouched by what has happened. Sepsis is often talked about in terms of survival, but survival is not the finish line. Recovery needs to be. And for many families, like mine, recovery is long, complex, and often unsupported. We survived sepsis, but no one taught us how to recover. If we truly want to improve outcomes, we need to expand how we define them. Not just survival, but what comes after. Thank you.
Kristine, thank you very much. Love the way you shared your journey from her birth to now, and we really hope that she's doing well. I would encourage the audience to please put in questions in the chat. And meanwhile, Kristine, there are a few things that really stood out in your conversation right now. Family. So when anyone who does pediatrics knows that you're not treating the child alone, you're treating the immediate family, and in some cases, the extended family as well. Reactive versus proactive care. I think that is also what came out very strongly in your conversation. As a patient advocate, what do you think are some of the big 2 or 3 messages you would like to leave all healthcare providers with, that they can give to families who exit hospitals with conditions like you were in?
Yeah, I don't know, I've had 11 years to reflect on this. I think I've done a lot of work. I think Brea said a lot of things that really hit home for me too. I mean, our experience was quite complex, right? I mean, I also had sepsis. So for me, I was also trying to manage my own recovery, and then having to go home. I had to just jump back into being a mom. And so, I mean, I had to look after a newborn baby. You just go back to doing what you have to do out of pure necessity. So I think part of it was really just there's not a lot of research. We know this. There's not a lot of research. There's not a lot of understanding around long-term implications of sepsis, other than knowing the experience that people have actually had or are naming. And I think that that's really important for us to understand, that hearing that lived experience from patients and families, that is what should be driving what some of these long-term care pathways could look like. Now, it may not be the same for everyone. Sometimes on discharge, these kids are perfectly fine afterwards, and they go back to being just like they were before they were admitted. But there are other families, and probably many of them, that have some way, shape, or form a long-term implication from what they've experienced. And it may not actually be the patient, the child themselves, but their family have some sort of long-term implication from that experience. There's lots of there's lots of support for many other patients that have been in an ICU setting, whether it's traumatic injury or some other illness or sickness. But sepsis seems to be the one that is we're not quite there yet on whether or not we've got some long-term trajectory follow-up care pathway. I think just asking the questions or naming that there could be, you may experience this, there may be something that pops up later that you could watch for. There's a validation to that for families, and that they're not alone. I think part of it for me was that it wasn't until I did the research myself, because the clinicians didn't know what was happening with Ellie when all these things started to come to light for her as she began to develop, that it was me doing the research around, could this have been because she was septic at birth? And then it all just started to fall into place. I think it's just that recognition that, you went through something that was very, very traumatic and very serious. That I think that is probably the most important thing that we need to start to recognize.
Absolutely. Like you said, survival is not the finish line. So there's a question for you, Kristine. Would education and handouts at discharge be enough, or would there be more engagement that would be required? And I
There's
think
lots of, I've even been a part of writing a handout at discharge, actually, for pediatric sepsis patients. I think yes, but you know what? In the moment, sometimes, again, you're so focused on survival. I think even I was so focused on survival. You're so overwhelmed by the experience that if there isn't something structured either in place to say, you know what, we're going to follow up with you at 3 months, in a month, at 3 months, at 6 months. I even think about if Ellie would have been on a structured plan, like a child that was preterm, because she was septic, then we would have been in a way, way different situation than we were with the trajectory of her care over the course of even of 7 years that we went through going back and forth to specialists. So I think, yeah, a handout is great so that you can go home, you've got something to read, you've got something to sit with when you're discharged. But I am a strong believer that there absolutely needs to be a structured post-sepsis follow-up plan for children that is set, that there are things that are checked: neurodevelopment, emotional follow-up, physical follow-ups, at a structured time point when they're discharged, and it does need to be long-term. We had things within the school system when she first went into kindergarten that we needed speech therapy, we needed OT therapy through the school as well. And it wasn't until we were in school that some of those things started to come into play as well. And it was absolutely, it could have been picked up through a post-sepsis follow-up care plan. So I think there needs to be a combination.
Kristine, just quickly, someone also asked, do you think there's any way this can be picked up in pregnancy? Sepsis can be picked up in pregnancy?
So, I mean, we could have a full, I mean, I could have gone on for a full hour to explain to you how I got sepsis, and I do think that there probably could have been, could it be picked up in pregnancy? Group A strep, I'm not sure. I think my sepsis was caused by a routine membrane sweep to initiate, like to get my delivery going. So I think I was just very unlucky. I think that I do think that there may be, I mean, there are group A strep is happening so often in postpartum cases that I do think that we need to think about screening for group A strep like we screened for group B strep. So, I mean, maybe I'll just leave it at that.
Thank you very much, Kristine. Thank you very much for sharing. And I think the key message we take here is that one size doesn't fit all in medicine. This needs to be individualized care, and survival is, like you said, not the finish lines. Thank you very much, and best
Thanks.
wishes to you and Ellie.
Thank you.
For our next speaker for the session is Dr. Hallie Prescott. She's a professor in pulmonary and critical care medicine at the University of Michigan and Ann Arbor Veterans Affairs Hospital, where she attends in the medical ICU and outpatient pulmonary clinic. She is an expert on long-term outcomes in recovery after sepsis and COVID. Her research program on sepsis care and outcomes is funded by the U.S. Department of Veterans Affairs and the U.S. Agency for Healthcare Research and Quality. She is a physician-led member of a statewide sepsis quality improvement collaborative funded by Blue Cross Blue Shield of Michigan. She also serves as a co-chair of the Surviving Sepsis Campaign Guidelines and a council member of the International Sepsis Forum. Dr. Prescott will be sharing her insights on sex and gender differences in long-term outcomes after sepsis. This will be a pre-recorded session, and there will be no Q&A segment for this session.
Well, hello, everyone. It's my pleasure to be speaking on sex and gender differences in long-term outcomes after sepsis. My only relevant financial disclosure is that I am a scientific consultant for Arabec Therapeutics, which is not pertinent to today's talk. Otherwise, I've listed my research funding, salary support, and pertinent roles. The question that I've been asked to address today is how do long-term outcomes after sepsis differ by sex and gender? And there's strong theoretical background and rationale for this question. We know that biological sex is associated with differences in innate immune response, adaptive immune response, and life expectancy. And we also know that gender may impact health-seeking behaviors, the healthcare services received, symptom perception, and also self-rating of health. So I'm now going to walk through three well-done and recent studies that examined sex and gender differences in longer-term outcomes from sepsis. The first study was published in PLOS One in 2023. This is a retrospective population-based cohort study that looked at about 63,000 ICU admissions with sepsis during 2018 to 2020 in Australia, and these were linked to National Death Index data. And the primary outcome was 3-year survival. The key goal of this study was to try to understand differences in long-term mortality from sepsis. So the cohort you can see was had more male admissions on nearly 29,000 versus 22,000 among women. Women were slightly younger and had lower illness severity, leading the authors to hypothesize that perhaps there was some delay in healthcare seeking behavior and evaluation among male patients that contributed to worse illness severity and just generally more ICU admissions among male patients. There was also a difference in the site of infection underlying sepsis. Women had a higher prevalence of urogenital infection, which tends to be more treatment responsive, and slightly lower rates of respiratory infection and abdominal infection. This next figure shows the key outcomes of this study. This is the survival curve for women versus men in the study. And you can see that these separate early. In general, the in-hospital survival was about 1% higher for female patients. And then this separation in survival grows over the course of the study period. Again, patients were followed out to 3 years or 36 months. And there was about a 5% absolute difference in 3-year survival among male versus female patients. The next study that I'll highlight is another retrospective population-based cohort study. This study used nationwide claims data for over 23 million beneficiaries in a large German healthcare provider. And in contrast to the prior study that focused very specifically on patients with critical illness and admitted to the intensive care unit, this study looked at all hospitalizations for sepsis, evaluating in total nearly 160,000 hospitalizations for sepsis in the years of 2013 to 2014. The women in the study, again, fewer hospitalizations for women compared to males, consistent with the prior study. Women were slightly older and more often admitted from a nursing home facility. And there was a difference in the baseline chronic conditions of patients. Women had lower prevalence of multiple chronic conditions, including chronic pulmonary disease, cancer, drug and alcohol abuse, and liver disease. And then looking at the details of the actual sepsis admissions, again, consistent with the prior study, we see differences in the underlying site of infection, women tending to have more urogenital infection, lower rates of respiratory infection, and then a similar rate in this study of intra-abdominal infection. They also saw that across the board, women had lower rates of acute organ dysfunction. Here I've just highlighted shock, which was about 2% lower, and respiratory failure, which was about 6% lower in women. And then generally women just had a lower treatment intensity, less critical illness. They were less likely to go to surgery during hospitalization, less likely to end up in the intensive care unit, which sort of further exacerbates this disparity in ICU admissions being more common in male versus female patients, as seen in that prior study. Women also less likely to end up receiving invasive mechanical ventilation or receiving dialysis during the course of the study. So this study focused on outcomes to 1 year. Here, this shows mortality across the age spectrum, and they've stratified this by male versus female patients. So you can see male survival across the age spectrum shown in red versus female survival shown in green. And then on this figure on the right-hand side of the slide, they show the mean difference for female patients, and then they highlight significant differences in that bolder red line. So you can see that 1-year mortality is significantly lower in female versus male patients under the age of about 30 and then ages 55 and up. So for a majority of this age spectrum, lower mortality among female patients, again, consistent with that prior study as well. This next slide shows the prevalence of cognitive disorders at 1 year after sepsis, again, across the age spectrum. So as you'd expect, these are more common among older patients. But for a large proportion of the age spectrum, we see lower rates of cognitive impairment in women versus male patients. And this is statistically significant for most of the age spectrum, about ages 75 and lower. And again, in the very oldest patients, we see lower prevalence of cognitive impairment after sepsis among female patients. This next slide looks at mental health problems. You can see that there's kind of this upside down U-shaped distribution. This is more common in the middle age spectrum. And we see that for most of the age spectrum that mental health impairment after sepsis is more common among our female patients. This was statistically significant among patients ages 40 years and under, and then about age 65 and up. And then the final outcome that they looked at was physical problems after sepsis. This also follows this kind of upside down U-shaped relationship, and it's just generally more common than the other outcomes, reaching nearly 90% in patients ages 70, 80, 90, and fairly similar across the age distribution. We only see significant differences during a sort of small, narrow range of ages. The third and final study that I'll highlight is this study that was published in JAMA Network Open last year that looked at sex differences in long COVID. This study examined the RECOVER cohort. This was a prospective cohort of patients hospitalized with COVID at 83 different hospitals in 33 US states. So in contrast to those prior studies that used administrative data and were able to capture the whole population, this RECOVER cohort is different because this was prospectively enrolling patients during the course of hospitalization, as opposed to capturing, for example, all patients hospitalized with COVID. The primary outcome of this study was the development of long COVID, which was defined via a self-report symptom-based questionnaire administered to patients at least 6 months following infection. And there was a number of different symptoms of interest shown down on the left-hand bottom corner that the investigators used to define the presence of long COVID in this study. So in this study, many more female patients were enrolled. And again, I think this reflects the difference that this was a prospective study enrolling patients who are interested in participating, as opposed to this, population-based study using administrative data. This was also a much younger cohort, didn't specifically enroll patients with sepsis, just all patients hospitalized with COVID. And again, consistent with prior studies, we do see significant differences in the baseline chronic conditions among male versus female patients. So in this cohort, there was a higher prevalence of immune compromise in our male patients, but higher rates of rheumatologic or autoimmune diseases, mental health disorders, and obesity among female patients. So this next slide shows the key outcome table. So in this primary analysis and their primary full model, there was a 31% increased risk of development of long COVID in female patients. That was a 5% absolute difference, approximately 20% of females and 16% of males having the primary outcome of long COVID. They then did a reduced model where they adjusted for slightly different factors and found similar outcomes, about a 6% absolute increase in the development of long COVID among female versus male patients. And then in their secondary analysis, they examined the difference across ages. As shown in that prior study, this kind of difference between outcomes in male versus female patients is not always consistent across the entire age spectrum, but seems to vary over time. And that was shown in this study too. So you'll see that in the younger patients, ages 18 to 39, there was actually no difference in the development of long COVID, but among patients ages 40 to 54, more striking differences, a 9% absolute increase in the development of long COVID, and then among patients ages 55 and older, a 5% increase in the development of long COVID in female versus male patients. So in sum, across these studies, we've seen consistently that men have worse survival, worse long-term survival after sepsis compared to female patients. We've seen that the patterns of post-sepsis morbidity appear to differ. So for example, women tend to have more mental health problems diagnosed, where men tend to have more cognitive impairment. The mechanism for these differences is still unclear, was not able to be sort of precisely sort of proven or determined through these prior studies. And they hypothesize a number of different potential explanations in these prior studies. So this may relate to some of the differences in baseline health that I highlighted throughout. This may relate to differences in health-seeking behavior, and that relates to both potential delayed presentation for sepsis among male patients, as well as differences in subsequent healthcare evaluation for symptoms that occur after sepsis. This may relate in part to the different types of infection and the more common urogenital causes of infection in female patients, which again tend to be more treatment responsive and have better long-term outcomes. We also know that there are differences in immune response mediated in part by differences in hormonal status among male versus female patients. And then also differences in symptom perception and perhaps the sensitivity of our outcome tools to identify or define or diagnose conditions in male versus female patients. So there's a number of implications for these findings. So in terms of implications for research, more work is certainly needed to understand the potential biological differences underlying these differences, which are important because they could lead to novel treatments or novel targets for treatment. Additionally, because of this consistent difference in long-term mortality after sepsis, interventional studies should report heterogeneity of treatment effect by sex as a routine part of reporting of clinical trials for sepsis. And then in terms of implications for our clinical practice, while the prevalence of long-term morbidity after sepsis differs, all survivors of sepsis are at increased risk for cognitive, functional, and mental health problems. And so at this time, it's still important to elicit and validate patients' experiences and connect them to available support services. I think at this time, there's insufficient evidence at present to support sex or gender-specific screening or treatment paradigms, but it's possible that this may be indicated in the future as more data accrues. I'd like to thank you all for your attention, and again, thank the organizers for the invitation to present today.
Thank you very much, Dr. Prescott. And again, gendered lens to medicine and managing sepsis is critical. We did hear about the implications, both in terms of research and terms of clinical care, what needs to be done to ensure good care and outcomes for sepsis survivors. Let's move on to the fourth speaker for today's session. I'd like to welcome Dr. Alicia Alcamo. She is a pediatric critical care physician scientist at the Children's Hospital of Philadelphia and the University of Pennsylvania, with a research focus on improving survivorship and long-term neurocognitive outcomes in children who survive sepsis. She received her MD and PhD from the Ohio State University and completed pediatric residency at Cincinnati Children's Hospital. She then completed a pediatric critical care medicine fellowship at the Children's Hospital of Pittsburgh, along with an NIH T32 fellowship in neurointensive care research. Since joining the CHOP Penn faculty in 2019, Dr. Alcamo has contributed to CHOP's pediatric sepsis, pediatric neurocritical care, and pediatric outcomes post-critical care outreach and research network programs. Her work aims to define trajectories of neurocognitive recovery after sepsis and identify risk factors associated with worse outcomes to better recognize and support children at highest risk. She is the recipient of an NIH K23 award studying neurocognitive recovery during the first year after pediatric sepsis. Dr. Alcamo will, of course, be talking to us about the brain in pediatric sepsis, how neurological dysfunctions shapes outcomes. Welcome, Dr. Alcamo.
Thank you so much. And thank you for this opportunity to talk about something I'm very passionate about, and I think parallels nicely within some of the recent talks in the session. I do have a few disclosures as listed here. All three objectives for this talk today. First, we're going to talk about what is acute brain dysfunction or acute neurologic dysfunction in pediatric sepsis, specifically highlighting the pathophysiology, discussing what the clinical presentation is, and also talk about how do we identify this diagnosis for both research purposes and clinical purposes. I also want to link the presentation of acute brain dysfunction to both short and long-term outcomes, and we will draw some parallels from the adult literature to highlight some of the gaps that we have in the pediatric literature. And lastly, I want to focus on reviewing kind of everything that we talk about from both a clinical and research perspective and put that into a framework that we can think about going forward. I think it's first important to start and just give a background about the pathophysiology of acute brain dysfunction during sepsis and highlight its multifactorial nature. This brain dysfunction includes direct neuronal damage, inflammatory dysregulation, mitochondrial dysfunction, alterations in cerebral perfusion and autoregulation, changes to the blood-brain barrier, and then also disruption of the neurotransmitters within the brain. And therefore, as you can imagine, the clinical presentation of a brain dysfunction during sepsis can really vary based on the pathophysiological reason for which you're seeing brain dysfunction. And there's many different mechanisms that we need to consider if we think through kind of how do we manage acute brain dysfunction. When I think about the clinical spectrum of acute brain dysfunction during pediatric sepsis, it's really a spectrum that will kind of range from just confusion or agitation all the way up until some more severe presentations like encephalopathy or coma. And then in between there have a little bit more of these distinct phenomena like seizures or stroke or delirium. And I think what makes this really challenging when we think about the clinical diagnosis of acute brain dysfunction during sepsis is that we actually don't have a true definition to actually define acute brain dysfunction. And there's some of these presentations that are easier to identify or name, like I already talked about seizures, and there's others like encephalopathy, which are a little bit more nebulous. When we think about how do we study acute brain dysfunction in research studies, we really use the definitions that go along with our contemporary sepsis definitions. I'm putting up a table here that looks through the different sepsis definitions and what the defining criteria have been for acute brain dysfunction, from looking back at the Prue criteria all the way up to the more contemporary Phoenix criteria. And what I want to highlight is that these definitions all rely on the Glasgow Coma Scale score. And as we know, that score was designed with the intent to actually assess neurologic injury at the time of trauma. But we have now adapted that into all elements of our clinical care, including sepsis. You can see that the cutoffs or the thresholds for the Glasgow Coma Scale score really vary based on the different definitions. I will say that Prue was a little bit more conservative, using a GCS cutoff that was less than 5 or fixed or dilated pupils, versus there were a little bit more flexibility or ability to identify a wider spectrum with some of these other definitions like the IPSCC or the Goldstein criteria that uses a little bit of a higher GCS threshold. I think I should highlight that Phoenix, being our more contemporary definition, uses a GCS score less than or equal to 10 or fixed or dilated pupils. However, I think there's a lot of challenges when we think about using GCS to actually identify acute brain dysfunction during sepsis. And this can probably parallel into a lot of other critical illness, but when we think about sepsis specifically, a lot of our children are under sedation or neuromuscular blockade if they're severely have severe multi-system organ failure. We have children that have pre-existing developmental comorbidities, and therefore their baseline GCS scores may not be normal. There is concerns that there's poor inter-rater reliability when assessing GCS scores between different providers. And then if we're using electronic health records to actually study sepsis and acute brain dysfunction, there's actually a lot of missingness in the electronic health record for documented GCS scores. Specifically, if we go back to that spectrum of acute brain dysfunction and we think about how does GCS apply to actually that spectrum, I will say that probably a GCS change will most likely capture those more severe presentations, but changes in GCS are less likely to capture those more transient presentations of acute brain dysfunction, especially just something like irritability or agitation. And this can lead to a lot of selection and misclassification bias and really kind of hinder us when we think about studying acute brain dysfunction. To combat that, I'm going to talk a little bit about work that I've done and in order to kind of understand a little bit more about the brain during sepsis. And part of that is work with developing a computational phenotype that has used EHR data elements that are indicative of clinician concerns. And so I parallel this to thinking about ventilatory needs and saying that the child has respiratory failure, or vasoactive needs and saying the child has cardiovascular failure. And that is that I will define a child as having acute brain dysfunction if they receive an MRI or a HES-CT, so some sort of neuroimaging, or an EEG. Those elements don't need to be abnormal. The fact that we actually just obtain neuroimaging or an EEG actually indicates to me that there was clinical concerns for some sort of neurologic change, or the administration of an antipsychotic medication to kind of capture the delirium cohort. I found that using this phenotype had better sensitivity and specificity than our traditional GCS definitions, and did capture more of, or a better prevalence of acute brain dysfunction compared to a gold standard clinician detection of acute brain dysfunction. Using that computational phenotype, I found that in our sepsis cohort here at CHOP, that 1/3 of patients actually had acute brain dysfunction. And this includes both ICU and non-ICU patients. And I think it's important to show here that the ICU population had a higher prevalence of acute brain dysfunction, which is not too abnormal or not surprising to me. But what was surprising is that still about 20% of patients not in the ICU actually had evidence of acute brain dysfunction. I will say this presentation of 34% in the entire cohort having acute brain dysfunction parallels the prevalence that we see in adult sepsis, where about 1/3 of patients have acute brain dysfunction. This 34% is generally higher than if you were to look at the prevalence by the GCS definitions. And I will say that I think it's important to note that in adult studies that ABD or acute brain dysfunction prevalence is as high as 50 to 70% of patients. And I think that's actually highlighting kind of what's closer to what we see in the ICU. Looking then for the relationship to brain dysfunction to our outcomes, we see that just looking in our CHOP sepsis registry at a single center, these are unadjusted outcomes, but the odds of death was 7-fold higher for children who did have acute brain dysfunction. And then using kind of inpatient rehab for survivors as a surrogate for morbidity, you'll see that the odds was closer to 10-fold if you did have acute brain dysfunction. Similarly, I've actually looked at the SPROUT data set, which is an international point prevalence study. This did use GCS-based measures to define acute brain dysfunction or neurologic dysfunction during sepsis, and looked at a composite outcome that looked at both death and new moderate disability, which was defined as a change in the POPC score, the pediatric overall performance category score at discharge. And what you'll see, and what I want to highlight, is that the timing of acute brain dysfunction is actually important. And you can see that acute brain dysfunction at any time is associated with worse outcomes. But it does appear that acute brain dysfunction that occurs after sepsis onset, so after 24 hours after presentation of sepsis, had an odds of almost 11-fold higher of having death or new moderate disability. Now I kind of want to shift and think a little bit more about long-term outcomes, and I really want to start to look at adult data because we are limited in what we have from a pediatric perspective. What we know from adults is that of all sepsis survivors, there is a 1 in 3 of these adult survivors will actually die within the first year after sepsis. And that acute brain dysfunction during sepsis actually predisposes them to have a mortality within this first year. In fact, there's been studies that have looked at the adult survivors who had neurologic dysfunction during sepsis, and there was a 6% absolute increase in their risk of death within that first year. We don't know what actually the risk, how this parallels to pediatric data. That's something that I'm working on, and I think that this is just indicating kind of how significant it is to have neurologic dysfunction during your sepsis episode and what may kind of imply as we go forward with as follow-up. I want to parallel then not just mortality, but thinking about actually long-term cognitive issues and neurocognitive decline. And the adult studies have very clearly delineated that there is a relationship from sepsis to cognitive decline. There's a 3-fold increase in cognitive impairment in sepsis survivors. And specifically, they look at memory, they look at processing speed, they look at executive functioning. And that goes out up to even 8 years after follow-up in some of these studies, that there is this sepsis survivors have worsening cognitive decline during that period of time. What we know as well is that the presence of delirium, which is obviously a form of acute brain dysfunction during sepsis, is linked to worse cognitive impairment. And in some studies, they've linked it at both 3 and 12 months post-discharge. Further, what we have seen is that adult sepsis survivors are also at increased risk for dementia at a period of time of 6 years after sepsis. And so just kind of further highlighting that cognitive decline that can happen in our adult patients. However, what does that mean for children? I think there's actually some limited data. I think we need to have a lot more information to understand what is the impact of acute brain dysfunction during sepsis to long-term brain dysfunction. But there are studies that are in primarily in the patient population that have experienced meningococcemia, whether that be include meningitis or not, or include shock or not. But I will say that there are signals that show that there's behavioral and emotional concerns in these survivors. They have a lower IQ, and they tend to perform worse in school and have behavioral issues in school. There's also been studies that have looked at ICU survivors overall in their neurocognitive recovery, and that there's about 1/4 of the patients in this study, that's by Alls et al., that have sepsis. And what they have shown is there was a reduction in executive functioning, which does parallel what we have seen in the adult sepsis survivors with their neurocognition. I think it's really important that we understand what is the impact on neurocognitive functioning for our children after sepsis, and especially in children. As they kind of recover, this is an issue that can impact well into the adulthood. And we have seen this in other chronic pediatric illnesses, such as cancer, traumatic brain injury, congenital heart disease, that the impact of their neurocognition lasts for an extended period of time. This will impact their academic achievement, which will obviously impact their occupational attainment, which would influence their earning potential, and then obviously impact their psychosocial functioning and their mental health. I have current ongoing K-23 funded work, which you've heard in my introduction, that I really hope to delineate these neurocognitive outcomes for children with sepsis, and really begin to understand how do we screen these children and how do we identify these morbidities so that we can intervene appropriately. So putting all of this together, I kind of want to think about the future of brain dysfunction, both during and after sepsis. So that acute process that's happening during sepsis and maybe the chronic neurocognitive issues that we're seeing after. And I think there's many things that we need to focus on as a community, both for our clinical practice and in research efforts. One is, I think that we really need to identify acute brain dysfunction. We need to understand, how do we screen these children clinically so that we can identify acute brain dysfunction? How do we improve our definitions so that we can actually study acute brain dysfunction and understand kind of the association to outcomes? Second is, I think we need to mitigate the presence of acute brain dysfunction. I alluded to the fact that the development of acute brain dysfunction occurring after that first 24-hour period is associated with worse outcomes. And so can we actually prevent kind of that late onset acute brain dysfunction that is associated most likely with our poorer outcomes? So identifying risk factors and like what is the role of different neuromonitoring techniques for us to prevent acute brain dysfunction from occurring. In addition, I think we need to prognosticate for our families and understand what is the level of acute brain dysfunction that we're seeing and how is that potentially associated with poor outcomes. So what is the role of biomarkers? There's been a lot of data on the adult side looking at different biomarkers associated with acute brain dysfunction, and how can we kind of translate that work onto the pediatric side? And then are there specific EEG features that we can use to evaluate and associate these with outcomes as well? And lastly, I think that we really need to identify, how do we screen these patients? How do we get standardized follow-up so that we can address their neurocognitive issues and promptly and intervene appropriately and improve their long-term outcomes? So that's what I have for you guys at this moment. I thank you and for this opportunity. I'll take any questions.
Thank you very much, Dr. Alcamo. I don't see any questions on the chat so far, but there are 112 people watching right now. So if you have questions, please post them on the chat. I think you've brought up a very important point, and one of our earlier speakers also spoke about this, how we need to move beyond survival for sepsis, like all the other diseases. So how do we think about brain dysfunction and how that impacts cognitive outcomes as the child grows is something that we need to think about, especially knowing that some of the statistics that you've presented about brain dysfunction occurring 24 hours after onset of sepsis. So when one thinks of sepsis, we think of it as an acute event, and when it's done and the patient leaves the hospital, you think everything is over. But it seems like, unfortunately, that may not be the complete story. So thank you very much, Dr. Alcamo, and we wish you good luck with the work that you're doing, and we hope that can inform a lot more evidence-based medicine that we practice for our children. Thank you.
Thank you. Thank you for this opportunity.
Thank you. Okay, our last speaker for today is Dr. Jerry Zimmerman. He is an emeritus professor of pediatrics within the Division of Pediatric Critical Care Medicine, Seattle Children's Hospital at the University of Washington School of Medicine, and a lecturer at Lurie Children's Hospital in Chicago. Dr. Zimmerman serves on many national leadership committees to advance pediatric critical care research. As co-editor of the textbook Pediatric Critical Care, now in its 7th edition, he is familiar with the academic landscape of pediatric critical care medicine. He has been engaged in sepsis research for over 30 years. More recently, he has served as chair of the Society of Critical Care Medicine Discovery Research Network. He served as a principal investigator for several grants. The LAPS, Life After Pediatric Sepsis Evaluation cohort that examined the trajectory of and risk factors for long-term functional status and health-related quality of life among children encountering septic shock. Also doing some genomic and phenotype work in pediatric SIRS and sepsis. They evaluate the utility of various gene mRNA expression signatures and proteomics to differentiate critically ill children with bacterial sepsis, severe viral illness, and non-infectious systemic inflammation. Recently, he has provided senior leadership for an international collaborative that established contemporary definitions for single and multi-organ dysfunctions. Please welcome Dr. Zimmerman, who will be talking to us about improving screening for neurodevelopmental outcomes after sepsis in low and middle income countries. This again will be a pre-recorded session, and we will not be able to take Q&A.
Greetings from Chicago. My name is Jerry Zimmerman. I would like to thank the organizers for inviting me to participate in this Global Sepsis Alliance event. Today I'm going to present for your consideration what I consider a very practical way of screening for long-term neurodevelopmental outcomes in children who encounter a septic event, particularly in low and middle income countries. My disclosures are shown here. Important is the fact that I received research funding from the National Institutes of Health for conduct of the LAPS investigation, which I will be discussing today. So the Life After Pediatric Sepsis evaluation, or LAPS trial, provides the infrastructure for an approach for long-term screening following pediatric sepsis. LAPS was a prospective cohort investigation that enrolled children between 2014 and 2017 among 12 pediatric intensive care units in the United States. These were all in a high resource setting, but the data or the ideas that I will show you today are generalizable throughout the world. In this LAPS investigation, children with septic shock were recruited. They all required vasoactive inotropic support. Most also required mechanical ventilation, and they were enrolled into the study following documented parental permission. This study collected a wealth of data, including demographics, measures of illness severity and organ dysfunction, as well as resource utilization related to therapy. In addition, this study, for the first time in pediatrics, assessed both functional status as well as health-related quality of life longitudinally during the first year following encounter with a sepsis event. Well, this slide demonstrates or displays the big picture from the LAPS study. On the x-axis, the time following admission to a hospital with septic shock, and on the ordinate or y-axis, the percent of patients with a particular characteristic. Overall, mortality in this investigation was 13% at 1 year and about 10% during hospitalization. So even in highly resourced settings, septic shock in children is still deadly. Mortality is still unacceptable. However, the big finding in this study was that at 1 year, 35% of these children who survived had still not attained their baseline health-related quality of life. So this is sort of a sobering finding. At 1 year following sepsis, almost half of these children were significantly affected by their septic shock event. Ultimately, this LAPS investigation developed a model for predicting poor outcomes. Poor outcomes here is defined as either death or severe deterioration, persistent deterioration in health-related quality of life. And I would add that this would include the dimension of neurodevelopmental deterioration. So this model has 3 main variables. The first was summation of PLOD scores. PLOD is a pediatric measure of organ dysfunction. It was derived and validated in children with sepsis. And in the LAPS study, every point accumulated in organ dysfunction during ICU admission was associated with a 1% increased risk of poor outcome. And so this is perhaps a measure of the intensity and duration of organ dysfunction. The second variable was the highest vasoactive inotropic score. Here, every additional point in this maximal score was associated with a 2% increased risk of poor outcome at 3 months. And this variable likely reflects the severity of the septic shock event. And then lastly, not unexpectedly, and ascertaining previous findings in adult sepsis, if a child encountered any acute pathological neurologic sign or event, this was associated with a 5-fold increased risk of a poor outcome. So any neurologic insult during sepsis is a strong predictor of a poor outcome, either death or a big hit to quality of life at 3 months. So this was the overall model that this investigation developed. But as I said, this study collected a multitude of variables that were all significant in terms of association with poor outcomes. We've discussed several of these already related to illness severity, organ dysfunction, and resource utilization. I would like to point your attention to the bolded text indicating the importance of deterioration of measures of functional status during ICU as predictors of poor outcome. The traditional measure here is the pediatric overall performance category score. This is a coarse instrument, but has been utilized for decades to assess functional status. More recently on the scene is the functional status scale, or the FSS, which is now available for use as it was specifically designed for clinical research among children with critical illness. Now, this functional status score is essentially an assessment of activities of daily living for children. It contains 6 domains, and they are mental status, sensory, communication, feeding, and respiratory, as well as motor. And these dimensions are scored from 1 to 6, 1 being normal and 6 meaning a very severe dysfunction in that category. The functional status score was underwent construct validation and calibration with the adaptive behavior assessment system, which is a well-known but more difficult, detailed tool utilized to assess functional status. It has been determined that an increase of 3 points in the functional status score overall, or more than 2 points in an individual domain, is associated with a clinically significant deterioration in functional status. Functional status score and the pediatric overall performance category score, these 2 tools are closely associated, and they have been studied in a few different investigations. However, my takeaway message is that the functional status score is more granular, and it is therefore more precise, particularly among the youngest children that we encounter in the pediatric intensive care unit. One of the secondary analyses of the LAPS investigation examined this idea of a change in functional status associated with an acute sepsis event. This change in functional status during hospitalization, is this predictive of long-term poor outcomes? So in this investigation, the functional status scale or score was assessed when patients were enrolled into the study. And this score was meant to reflect the status of the patient in the month before they were admitted to the hospital. And the score was assessed again at hospital discharge, or about 28 days later if the patient remained in the hospital. In the LAPS study, health-related quality of life that contains elements of neurodevelopmental insult was assessed in 2 ways. One was the Stein-Jessup tool, which was utilized for children with severe developmental delay. And in this case, among 88 patients with complete data, this extent of change of functional status during hospitalization for sepsis was associated with a lower Stein-Jessup measure of health-related quality of life in this population with severe developmental delay at baseline, associated with poor outcomes at 3 months, but not 12 months. The other way quality of life was measured was the Pediatric Quality of Life Inventory. And using this tool among children who were essentially developmentally typical or normal, a worsened FSS during hospitalization for pediatric sepsis was associated with lower quality of life at both 3 months as well as 12 months. I previously mentioned the importance of a neurologic insult occurring during a sepsis event. And this is very predictive of subsequent neurologic morbidity. Even when controlling for neurologic outcome, children who are assessed with the Pediatric Quality of Life Inventory, still this change in functional status score, a deterioration of functional status during hospitalization for sepsis, remained significantly associated with later health-related quality of life at both 3 months and 12 months. So mortality alone does not adequately describe the overall impact and trajectory of pediatric or adult sepsis. Children come to us with their own genetics, epigenetics, biochemistry, and physiology, and this defines their comorbid, chronic comorbid conditions and their baseline quality of life and functional status, neurodevelopmental status, if you will. These children come to the hospital, and if resources are available, to an intensive care unit to treat organ dysfunction associated with an infection. This is how sepsis is currently defined by the pediatric Phoenix sepsis criteria. And if there are resources available in the hospital, in a pediatric intensive care unit, these resources help support the patient during resolution of organ dysfunction, and providers typically herald this as a great save. And of course, this is important. But ultimately, patients and parents are interested not only in acute survival, but more importantly, long-term thriving in terms of their functional status as well as health-related quality of life. So in addition to ensuring survival from sepsis, we critical care providers should also begin to focus on optimizing a child's long-term health-related quality of life and functional status that include the domains of neurodevelopment as an equally important goal for pediatric sepsis critical care. And what I've tried to show you today is that use of this simple tool, the functional status score, which is easy to administer, entails no cost, is easily translatable. This is a tool that can be utilized to screen patients who are at risk. So finally, after the infection, the red flag here is that hospitalization for sepsis and critical care for organ dysfunction and any acute deterioration during hospitalization of functional status, utilizing this functional status score, for example, as a tool to measure it, should be a trigger for clinicians to identify these types of patients as a high-risk population for new limitations of functional capacity and long-term significant morbidities that become evident as impairment of health-related quality of life and need for ongoing healthcare resource utilization. Thank you very much for your attention. If anyone is interested in a copy of this presentation, send me an email and we'll be in touch. Thanks very much. Enjoy the rest of the conference.
Thank you very much, Dr. Zimmerman, and all the people who joined this session. As we close today, we encourage you to continue this momentum by visiting our website, signing the World Sepsis Declaration, and staying connected on various social media platforms, including LinkedIn. Your engagement helps amplify awareness and drive meaningful change in sepsis. We would like to extend our gratitude to the speakers who shared their valuable insights today. Thank you all for being a part of this important conversation. Have a good day, everyone.